Good evening, everyone, and thanks very much for joining us. The Arkansas General Assembly will meet beginning Monday for a fiscal session to approve a state budget. That budget, as proposed by Governor Beebe, includes a highly controversial component, money to continue the state's private option program, which basically uses federal Medicaid funds to allow some lower-income Arkansans to purchase health insurance. And yes, the larger political canvas is the Affordable Care Act, which even the president has been known to call Obamacare. The private option was approved by the legislature last year with few votes to spare. The vote this year is thought to likely be at least as close, perhaps closer. With us, state legislators from both chambers on both sides of the question, and in something like the proportion the initiative was adopted last year. Our guests: State Senator David Sanders, Republican of Little Rock, one of the architects of the private option. Representative Nate Bell, Republican of Mena, who takes an opposing view of the initiative, and State Senator Keith Ingram, Democrat of West Memphis, who is the minority leader in the Senate. As one of the leaders of the private option, this all boils down to numbers. Frankly, as we look at the equation. Senator Sanders, where are you in the Senate?
No, we count votes. I mean, obviously we knew when we passed this last year that it would be close. It is one of the built-in innovations into the policy, and that is this: we knew that every single year we would have to re-up. We would have to authorize funding for it yet again. And by nature of the policy, it puts you in a position to negotiate with the federal government. So it's sort of one of the policy innovations. You've seen it for years. Keith and I have seen it. You can pass something that's innovative, and then in a matter of years it is not innovative because other states have moved beyond you. I think this is one where that is built in. I think we can get there, and I think the important thing is ultimately in the private option, the reason why we came up with it is, one, I and many of my colleagues do not support the Affordable Care Act, and we've seen some of the things in the rollout and some of the reasons stated for being against it, actually come true. What we wanted to do was something different, and what we were told, even up until this, if we were to go back a year in time, we were told that there was no flexibility. It was a take it or leave it proposition. Either you're going to expand Medicaid, the government-run, government-managed healthcare system, which has been utilized to provide health care for disabled and lower-income individuals, or you're going to do nothing. And this idea of premium assistance, using those dollars to buy private insurance, that has been proposed on numerous occasions by other states, other governors, members of Congress, but it had never taken hold. And we knew, because we read not only the Roberts decision, but we also read the Affordable Care Act, that states actually were in more of a driver's seat than maybe others thought. And,
because the Supreme Court had ruled out a
the mandate goes away, and they said this because there have been other innovations. In fact, there have been other states that have taken up global Medicaid waivers, block grant programs, and as administrations change in Washington, so too did the terms and conditions. And if the state didn't accept them, Washington could say, well, fine, then we'll take the rest of your Medicaid dollars. With the Roberts ruling, that doesn't apply here, because Roberts explicitly stated that you can't hold the states hostage. You can't insist on that you expand, but then you can't use the other Medicaid dollars to get what you want. So essentially, we're not even with the federal government, but what Roberts did was to elevate. So it put us in a position to, in fact, begin the negotiating process, and we did.
Well, you're negotiating now within your own caucus. I have one guy, and when you say, I think we can get there, it seems to suggest you're not there now.
Well, I think if you were to read the public comments, look at what has transpired over the past few months, if you're just counting votes, I'm not sure we're there if we have the vote today or tonight or tomorrow. But I think what has happened is, within a regular session, there are a number of issues that are before the legislature, and you're easily distracted by that which you want to pay attention to. In this case, quite frankly, there are major issues facing the state, but you don't have the luxury of not paying attention or not digging in or not asking questions. And that's what you see a lot of lawmakers doing now. A lot of lawmakers voted no because, quite frankly, this was a estimate. It was an idea. It was a concept. Well, now it's operational, and not only is it operational, we're seeing people sign up for private insurance coverage, which in other states they're going to be on straight Medicaid or nothing at all. You see states like, Iowa has emulated us. They basically took our model and crafted it for themselves and received permission to pursue it. That's with the Republican governor. You've got the governor of Pennsylvania who is now emulating us, and perhaps the most Republican state in the union, Utah, is now emulating Arkansas, or planning to emulate Arkansas, and looking very seriously at the private option. So you see that is happening, and we have rates now. We have individuals who have signed up. Sort of the dire. There were even some, and again, I think they were reasonable criticisms. Some didn't believe that the waiver would be granted, and if it were granted, there were other critics who thought the annual premiums for health insurance would get closer to $10,000. Well, they did approve the waiver, and the annual premiums are actually half of what some of the critics predicted. And you know what? Some of those men and women acknowledge that, and they say, you know what? You're right on this. So I think at the very least, my case is that we deserve the chance to continue to move forward. And we're working on the second phase of this, which is the development and the implementation of health savings accounts, which we're not going to solve the healthcare crisis in America unless everyone stops being users of healthcare and becomes consumers of healthcare. We have a stake in the game. We're working on that. Transition of populations off the existing fee-for-service program onto the private option, but also developing the cost sharing for people at 50 to 100% of federal poverty. Let's have some stake in the game. So I think we've maybe earned the right to continue ahead and see where it goes. And we will have this, if we are successful, we will have the exact same policy discussion this time next year.
Well, Mr. Bell, let me come to you in just a second. But Senator Ingram, your caucus held together, well, both in House and the Senate, your conference, Democratic colleague. Any change on that score?
No, I think everybody is unanimous in their support as they were the last go around. And I think the thing that's very unique about what David and Senator Dismang and when I'm at national conferences, I have people that seek me out and say, how did y'all accomplish this? And I said, quite simply, the members of the Arkansas legislature put the people of the state of Arkansas ahead of politics. I wish they could do that in Washington. We managed to do that in Arkansas, and bright folks like David and Jonathan and a group worked on this. And I get calls. Wyoming, I received a call last week from Wyoming wanting to know, how did y'all do this? It's so innovative. So I'm pleased with where we have been. I'm excited about the options moving forward on this. And as David said, this is a piece of legislation that we can derive best practices from and strive to make it even better session to session to session.
Well, it's probably an appropriate point to note to our audience. We were going to have a slightly larger panel, but nature intervened with ice and snow, so we had some fall off there. Mr. Bell, your Senate colleague says it's now operational and no longer conceptual. Does that alter your opposition in any way?
Well, my opposition to this from the beginning has been basically come down to 2 points. And those 2 points were, I've never believed the Affordable Care Act, or Obamacare as it's commonly known, was going to be consistently implemented. I felt like it was bad policy. And based on that, I've never felt like it was wise for us to build state policy that was dependent on it. And so that was my primary reason for opposing this. Secondary reason, and ultimately why I cast my no vote, was because of spending. And, no matter what face you put on this, there was a net increase in federal spending in the state of Arkansas of about $1.1 billion a year. And I can't call my congressman and complain about the federal government printing money in good conscience when I'm the one authorizing spending it. And from my standpoint, it's just a consistent deficit hawk. And David knows I voted against an $8 spending increase my first term. I don't believe that it's appropriate that I sit here and ask the federal government to send me more money to spend when I'm complaining about what they're doing in Washington.
Mr. Sanders.
Well, I mean, it's hard to disagree with that because
Well, you can't in terms of the federal dollars.
You can't. But I'll say this. I mean, and so I think folks who have been around the Medicaid system in Arkansas for a long time know that we're fairly unique. We are not only governed by the executive branch and the legislative branch, but we're also governed by the judicial branch. There are an inordinate number of consent decrees and judicial orders that are in full force of the existing Medicaid program. There are 43 states in the union that have adopted some sort of Medicaid managed care model where you have groups that's their core business to do it. We're limited in Arkansas, and most states in the union actually cover a higher number of people up the income scale. We cut it off at 17%. Mississippi, for instance, covers
that's a key point in this overall debate that a lot of people miss.
Yeah, 45%. Mississippi, in some states, the state of Wisconsin, they cover it up to 200%. They scaled their Medicaid program back to 100%, shifted everybody over that into the exchange, and just added 146,000 people to the fee-for-service program in Wisconsin. I might point out that Governor Scott Walker just announced that they're running $1 billion surplus as well. Here's the point. We're limited in what we can do in terms of really reforming the system. This is, by any estimation, Nate agrees, it is a reform, but we're taking a chance. If we're right, if we're 1% right, 2% right, 3% right, that this is a better way to do it in terms of the administration, in terms of the administrative cost, in terms of waste, fraud, all those things that we know are part of the Medicaid program, then we have, not just theoretically, but operationally, given other states a better model to cover people that they're already covering. So, yeah, I can't disagree with Nate at all. But if we're right, this has never been done on this scale before. If we're right, then the potential impact to the federal budget is potentially it's gigantic, and you actually have a process where you're bending the cost curve down. And I want to point out, where we are today is not it at full operation. It only works. Keith knows this. He has a self-insured plan for his employees at Razorback Concrete. We all know this because we're working on teacher insurance and state employee health insurance. You look at innovators like Walmart and people who used to be a laughingstock in the benefit world, but now they lead. We know the only way to fix this is to drive consumerism into the system. Former Governor Mitch Daniels in Indiana did this in his Medicaid program with the power accounts. Other states have done this. We're emulating that. We're going to hopefully take it on a much larger scale. I think this is potentially a model for the rest of the country, and it is precisely why people of multiple partisan stripes are engaging us and want to know what's going on.
Let me go back to Mr. Bell for just a second. Is it beyond the purely fiscal, though, Representative Bell? Is it beyond the dollars and the cents into thinking of it conceptually as a state investing in the well-being of its people?
Well, again, we're not talking about state dollars here. We're talking about federal dollars, and so we're making that decision to spend those federal dollars. But clearly, and I mean, the federal government has made a decision to do that. I disagree on the whole with that policy, but I want to go a little deeper into this in what David was touching on, because I think there are some areas where we have some agreement. Actually, a lot of agreement. And David and I have been friends for a long time and worked together closely on a lot of things. In concept, I don't disagree with his overall concept. I disagree with the way we're approaching implementation as a whole. Had he come out and pursued a CMS waiver to do this as a 50,000 or 100,000 person demonstration project, I probably would have been for it. But it's the scale of what we're looking at on something that's unproven and based on something that, again, has been demonstrated. Obamacare has been somewhat more like quicksand to try to build on. It's just been, the rules change every day. It's complicated some of what they've had to deal with in putting this in place, because pieces of it, you're just chasing a moving target, and that's very difficult to build really sound policy on.
Yeah, Senator Ingram, it is a moving target in a sense. Your employees have health insurance through your private sector corporation. A heck of a lot of people in your side of the state don't, as elsewhere in the state don't.
Well, it impacts not only not only the individuals but the providers. I have 3 hospitals in my Senate district that are holding on by their fingernails, and without this, I don't see how they will survive. And if you think in terms of economic development, how can you bring economic development to an area that doesn't have proper health care, that doesn't have healthy workers? So this has many ramifications above just the policy.
Mr. Bellamy.
Steve, I want to step back, because there's something that I think we're kind of going back and having the old fight all over again, and I think we're at a different point now. We have a law that is the law. The private option is the law in Arkansas. We're coming into a fiscal session, and we're here today to talk about a preview of what we're looking at legislatively this time around. I think based on public statements, and I think David would agree with this, and probably Keith, there are enough public statements out there of people that are opposed that, at least in its current form, the private option probably would fail if it were put to a vote today to fund it. So for several months now, I've been trying to look at and think ahead as to how do we
fail in the House?
I think it fails on either end if there were a vote today.
But in your chamber,
reaching that supermajority.
Reaching that 75% supermajority. That's a very high bar.
Well, you were 2 over last time, so.
But there are several of those who, at least privately and in some cases publicly, have stated that they probably wouldn't support it again. So the question becomes, obviously that's a dynamic situation, and who knows how that turns out. But I believe it would not be prudent for us to not be looking at alternatives and what can we find that we can find agreement on and get broad agreement to move forward. And that's what I've been trying to work on, and we're making some progress on alternatives. There are a number of people who have acted in good faith based on the private option being law, who maybe had private coverage and dropped it because we had this. If we just defunded this and walked away from those people, frankly, I think it's morally wrong to do that to them. We've got to put ourselves in a position where, if the private option goes away, those folks have a path to continuing to have access to health care when they did everything right before.
Well,
so
have you designed that path yet?
I believe we're very, very close to having something that will work, yes.
All right. Have you shared this with Senator Sanders?
Top lines, yes.
And
thought?
thought?
Obviously, again, I would go back to what I said at the outset, and that is, we have the ability to do things. In terms of negotiating with the federal government, we're in the process of developing. You've got former Governor Mike Leavitt, former Republican governor of Utah, former President W. Bush, HHS Secretary, working on the amendments to the waiver with the HSAs, the transition of populations, all those. So that's happening now, and we'll have something hopefully to share about the policy soon and get lawmakers' input. But I think there are some other things that we can do. I think there are opportunities here, and it was always my view even that, it wouldn't always look exactly like it did when it was passed, and that because let me give you an example. Iowa, when they emulated us and filed their own version of the private option, they requested and received authority to waive non-emergency transportation. And quite frankly, one of the criticisms, I think valid criticisms of the private option was at the time that, you're going to be responsible for covering all these WRAP services. These are services provided by Medicaid that aren't provided with private insurance. Well, as we work through the process, the only real remaining WRAP benefit, and there are several, was non-emergency transportation. As a result of their innovation, we'll seek the same permission or seek the same amendment to our waiver to waive it, because you're not eligible for non-emergency transportation if you have access to transportation. So it's not a big ticket item, but that is sort of a demonstration of how this works. So
Are
yeah,
you
I think
looking,
we can
Mr.
get
Bell, are you looking for big ticket items?
Well,
The
again-
senator seems to be suggesting that this is kind of, not to put words in your mouth, tinkering around the edges or maybe moving a...
I don't know if it's tinkering around the edges.
Actually, small changes can have big impacts on the
Okay,
spending.
that's what- yeah.
And that's what I think a lot of people miss in this overall discussion. My concern with this has been from the beginning. Bottom line, spending in the unstable foundation. So what I'm looking to do with any proposal that I'm going to be supporting is to find ways to curb that spending, to bring it back more in line with what I believe are conservative principles, and to find ways to look at improving the efficiency of delivery at every level. And I think we have some common ground there. There's a number. Fundamentally, I don't believe the private option is good policy. Obviously, I disagree with my colleagues on that, and I was a part of a small minority who felt that way. One of the beauties of the way our system is designed here in Arkansas of appropriations is minorities can have some leverage. And in this case, hopefully we'll be able to leverage it. And at the end of the day, we walk away with a better policy for everybody. I'm kind of a fan of that supermajority that we have on appropriations because of that. Because you are forced to find ways to work together, and I think that's good. I think that benefits the people of the state of Arkansas. And
Senator Ingram, in your caucus, how much, call it tinkering, calling it redesign, retrofitting, whatever you call it, how much can your caucus handle?
Oh, I think we're open to any fresh and new ideas. I think just sitting here, the thing I think is so refreshing is that members of opposite parties are talking about how to fix something and working together rather than what's happening in Washington where the divide is so much they won't even meet and talk. I mean, I think that's refreshing, just like what's happened in this state, and I think the private option is a perfect example of how parties can work together for the betterment of their state. And if we had that on a national level, what we have in Arkansas, I think it's unique. So yes, I think there's give and take. There's things that are starting to happen. There is we're only 6 months roughly, I guess, into this, and the results so far have been very positive. We know a little bit more in hard numbers, as David said. It's not just a concept; it's a reality, and I have gotten letters and emails from providers that have been pleasantly surprised as to how it's operating in the rollout. And let me say this, on the national rollout, the problem with affordable care, I don't think the federal government ever thought when they introduced this that we would not all have state exchanges. I think that was a big surprise. I don't think they were prepared to handle the number of states that went into the federal exchange. And I was on Insurance and Commerce when it was brought up, and David, I'm not sure whether you were on that committee or not, but we couldn't get the votes to have a private, the exchange, a state exchange. I think looking back, that was a mistake, but we've made the best of what we had to work with.
Well, there does seem to be a parallel with Washington, gentlemen, in that the rift appears within the Republican Party in Arkansas writ large, as in the House, to some degree in the Senate too as well. Is this a fiscal divide or a philosophical divide?
both. Speaking as someone who is opposed to private option, I think it would be fair to say, and I think David would agree with me, that my reasons for opposition are different than from some of the folks who have opposed it. There are folks who fundamentally believe that this is just implementation of Obamacare, and I don't. I believe it's actually ingenious policy that has some very good high points. I oppose it on the two grounds that I've stated several times, and continue to believe that it has potential. In fact, I was when the original votes came up. I told David, I don't know how many times, if you can get this thing budget neutral, I can be for it. But they weren't able to get there, and that became the stalling point for me.
In addressing the health problem, is budget neutral possible?
Well, again, in terms of one,
you got a system that's already operating, components of which are already operating
sure,
at a deficit.
I think it's very important, and this is a key distinction Arkansas has compared to any other state. There are a lot of states that followed the Obamacare ACA Medicaid expansion. They get to spend that money for 3 years. They have no cost control consideration. We do not. We have to maintain budget neutrality. So when you start talking about non-emergency transportation, or I've talked to providers, particularly some dentists, who had some private option folks show up and they were getting their teeth cleaned. Well, dental's not covered in the private option policies. Actually, one company actually does. They included it sort of as an enticement, but they're like, we really understand that this isn't Medicaid. You're not just throwing all the benefits. I mean, I was looking the other day, if you look at what Wisconsin covers in their standard Medicaid program, it's much larger than ours in terms of the private option. So, yes, innovation has to happen. It's necessary. We have to learn from the examples of others. We have to learn from the experience of others. And I think that we can do it in a way that ultimately the public good is served. And again, this is not, the private option is not an end to itself. It is part of a larger process to drive consumerism into healthcare and make us cost conscious. And we're working on policies to make populations that have been out of the insurance market and who are in it now to be cost conscious. So a lot of work to do. A lot of work to do.
Mr. Bell, I'll give you 10 seconds because that's all we got left.
Well, just
you get the last word.
Well, thank you.
Just good at that.
We have a situation here where I think there's room for common ground. It requires that everybody ratchet down the rhetoric, find a way, like Senator Ingram said, to work together for the good of Arkansas, and I think that's possible to do.
And with that, gentlemen, I do have to cut it off because we're out of time. I hope you will come back at some point in the very near future. Thank you. Thank you for watching, and we'll see you next time.